Thank you all, and thank you, Omics organizing committee, for inviting me to speak. It's a pleasure. This is going to be a little different from your presentations this morning, as well as the engineering presentation just prior to me. This is the hospital where I work in. It's beautiful, I think. The presentation will be along these lines. We'll focus a lot on skin infections, the spectrum of the disease, how we choose antibiotics, how long we treat infections, and then we'll try to have some fun by showing pictures of things that were sent to us for infection and they're not getting better. Why? Because they're probably non-infectious. And probably we can have like an interactive session where you can call out the diagnosis. So we see a lot of these patients with cutaneous lesions. This is a very classic cellulitis patch with these honey-colored crusts, which is classic for staph infection. And then we see these lesions, which we call purulent cellulitis, where you have pus coming out. And so usually clinically, as an infectious disease specialist, we divide cellulitis into non-purulent cellulitis and then purulent cellulitis, and we choose antibiotics based on these clinical presentations. You classify infectious disease like this. The primary lesions and then complications of underlying cutaneous infections, and then cutaneous manifestations of systemic disease, and then very bad infections. But we define, when we come to clinical choices of antibiotics, we define infections along these parameters. And there are specific reasons why we do that, because we'll see that the choice of antibiotics for this is going to be different from the choice of antibiotics for something like this. This is an example where, the first few pictures you saw were very simple cellulitis or simple abscess. And then this looks like a very nasty infection. It's nasty because it's going deeper down into the tissues. And so we call these things like necrotizing fasciitis, where your choice of antibiotics will be a little more aggressive. And interestingly, and very rewardingly for us, is patients like this previously, like 20 years back, would actually go to the operating room and have a massive debridement and have a month of recovery followed by skin grafting. But today we've got very aggressive antibiotics, and we can actually cure this with antibiotics. And this is the same patient. She didn't lose her leg, she didn't lose her skin, did not need plastic surgery. All infections without surgery. So this is a nasty infection. It's gone down to the tissues. This patient required plastic surgery after we finished the course of antibiotics. We do deal with infections in patients with systemic illnesses, and as we classified clinically, this is a patient with severe uncontrolled diabetes. This patient gets secondary infection because of the presence of the open wound. So we not only need to clear the infection, but we need to close this wound, and that's where good control of their systemic disease comes into play. When choosing antibiotics, we also have to deal with complications of surgery. So this is a patient who underwent a breast biopsy, and that got infected. And this is now a hospitalized patient. The choice of antibiotics will be a little different than as an outpatient. This is a patient who's post-op, done by a podiatrist for fixing a knuckle deformity, not a knuckle, a toe deformity, which we call hammer toe deformity. And then they put a pin to keep it straight while they recover. So these patients, we have to cover organisms which are associated with hospital-acquired or healthcare-associated infection compared to community-associated infections. We sometimes have to deal with prosthesis. So now we have more and more patients who are undergoing plastic surgery. So this is a lady who had a scar under her chin, and then she has this plastic surgery device where they put in the device under the skin, and then every week or 2 weeks they expand that. So when that gets infected, it becomes pretty tricky. Is this an abscess underneath that needs to be cut and excised? Or is this just that expansile device, which is superadded infection? So I tried to get this device out, but the surgeon refused. So we have to work through with our patients. So this was an infection of the expansile device, but we got through this patient too without having to remove the device. When it comes to choice of antibiotics, it's not just the antibiotic that's important, and we'll go through a couple of slides where we see the importance of surgical debridement, and it's very important to treat what caused the infection, otherwise they'll come back to you. This is a slide I've put out here is to make the point that if you have an abscess, you can try the best antibiotic around. We say sometimes when we get consults, they say, please give us a strong antibiotic. There is no strong and weak antibiotic. It's the appropriate or inappropriate antibiotic. So patients sometimes do not respond to outpatient treatment, and then they say, let's give them the strong IV antibiotic. But this slide shows that if you have an abscess, if you don't drain the abscess, you're not going to get better. But if you drain the abscess, you can get better without antibiotics. This is a case where this is an abscess. It has to be drained, and there are some studies that show without antibiotics, this patient can get better. This is another study. So this study shows that you can give them, after you drain an abscess, you can give them a placebo. You don't need to give them antibiotics, and then you still have the same results. I like to take pictures, so we do a lot of pictures, and this helps us for a couple of reasons. Sometimes patients are very upset when they come with this bad infection. They think that they're going to lose their leg. So we have pictures to show the patient, hey, you're going to get better. Don't get worried. So I like to take before and after pictures. So when we choose antibiotics, there are a large number of antibiotics in the market. There are more and more products which are coming out, shorter duration of therapy. This is one of the latest antibiotics. It's a 4-day therapy, oral antibiotics, and they have compared it to IV antibiotics for 10 days, and they show excellent results with oral antibiotics. This is very fast. It's called dalbavancin, once a week antibiotic. You give them an antibiotic IV one day, send them home. They're supposed to get better. And then you repeat a dose after a week, and that's supposed to give you a 14-day treatment. This is a once-a-day IV antibiotic that we can actually do as an outpatient. Previously, we would admit all these patients with severe infections. Now with this once-a-day IV antibiotics, we can actually do once-a-day antibiotic as an outpatient. This is a twice-a-day pill antibiotic that can be taken by mouth, which has actually great bioavailability, as good for skin penetration as IV. So how do we choose between all these very fancy antibiotics in the market? The pharmaceutical companies want to say, oh, my product is better than yours. When we see those clinical pictures that I've shown you, we have to decide which antibiotic to choose. So usually when you have a very severe infection, we choose a broad antibiotic, and then we call what is called de-escalate. We need cultures to guide us. So when the patient comes in, we get deep tissue cultures. We start very broad to cover a lot of organisms, and then as the cultures come back, we de-escalate or narrow the spectrum of antibiotics, and we'll go over a couple of cases. We have to also, if you have an ulcer on the skin and you just swab, you're probably going to get 3 or 4 bacteria. So we have to distinguish between the bacteria that are really causing the problem and hence need the antibiotic targeting them versus a bacteria that's just sitting there. And again, duration of antibiotic depend upon the depth of the infection. And then do we admit everybody or can we treat them as outpatients? If you go to cdc.gov, there's a nice website which talks about choice of antibiotics for skin infections. So the big issue here in America is MRSA, or MRSA, methicillin-resistant Staphylococcus aureus. So it's not only healthcare-associated infections, these are also seen in the community. So does every patient need to be treated for MRSA? So we have some guidelines that you could review on the cdc.gov website. They talk about these different antibiotics that are available for treatment of MRSA. The interesting clinical point here is that if you choose an antibiotic that kills methicillin-resistant Staph aureus, it's likely to kill methicillin-sensitive Staph aureus, it's likely to kill Streptococcus. So why don't you just choose this drug for everybody? Well, the question is, if you use it too much and you use it, inappropriately, you're probably going to lose it. And that's the principle of choosing targeted antibiotics. Just a brief summary of antibiotic choices that we can have. And again, it is all available on cdc.gov. So we will, when we see patients and we have these very nasty looking infections, we get our surgeons to debride the pus from the top and then get deep tissue cultures. So initially you get a lot of bacteria. So when we make a choice of antibiotic, we need to really hit them on a lot of organisms. So we'll cover gram-positives, we'll cover gram-negatives. So we usually land up choosing 2 antibiotics. And then as the cultures come back, we de-escalate. So here is a very nasty looking infection. And somebody would say, oh, this is so nasty, this has to be MRSA or MRSA infection. It's probably likely to be MRSA, but sometimes we do get surprises. So the deep tissue cultures are very important. And then in this patient, the deep tissue culture revealed MSSA, not MRSA. MRSA is resistant to all these antibiotics. So it reveals MSSA, and these are the antibiotics that we usually use for skin infections. So in that patient, we could have used any of these, oxacillin, cefazole, and unicin, and then we can save drugs like vancomycin for the MRSA infection. So he healed with good antibiotics, but if you see here as dermatologists, you will notice that we need to take care of these dirty-looking nails because they are full of fungus and full of bacteria. He needs to use good elastic stockings or good elastic compression to get rid of the edema and a lot of moisturizer to help to recover from this infection. This is another patient. Here we see that the organism is methicillin-resistant Staph aureus. Methicillin, because it is resistant to these medications. So it is resistant to oxacillin. We call it methicillin-resistant Staph aureus. And so we could choose drugs like vancomycin, which is IV. We could use doxycycline. We could use ciprofloxacin. And we'll go over a few examples of how to choose these antibiotics. In this case here, we see that this is an MRSA, but it is resistant to that once-a-day IV antibiotic. So, although we have very good effective antibiotics, we do have that occasional patient that does turn out to have resistance to your antibiotic that you thought would kill it. So that's why cultures are very important. Sometimes we do have more than one bacteria. So we have an Enterococcus faecalis here, we have an MRSA organism. So instead of choosing 2 antibiotics, we like to see which antibiotic can kill both the organisms. And in this case, it would be vancomycin, because this organism, though it was sensitive to ampicillin, MRSA was resistant to ampicillin. So we would use vancomycin for this patient. All these slides emphasize the use of deep tissue cultures in helping the infectious disease specialist make the choice of antibiotics. There are some cases which are a little unusual, and that's why our infectious disease classification was cellulitis, abscess, others, complicated patient. This is a dog bite. This is a dog bite. This is a cat bite. So these patients get infected with organisms that are a little unusual. As expected, they can be infected with organisms that are present on the skin. When the dog bit the hand or the cat bit the hand, the infection from the patient's own skin can go in. But the dog and the cat, their saliva has some unique organisms. So we usually try to take care of those organisms. But when you get deep cultures, you are sure that you are going to kill it. And so this Eikenella species is often seen in the mouths of animals. Some very, we say MRSA and Streptococcus is the most common organism associated with skin and soft tissue infection, but sometimes we do get gram-negative organisms too. Another gram-negative organism. And then we use these culture results to help us guide the antibiotic choices. I put this slide up here because this was a referral to us for infectious disease consultation, because they did a culture of this pus and they found no choice of antibiotics, and they couldn't figure out what antibiotics to use. So I put this up here to show that if you do culture from your skin, we'll get more than one organism. Does not mean that all these bugs need to be treated. So this patient's pus here on the skin grew out this multiple organisms here. It is very difficult to choose the antibiotic. We can make a choice if we are forced to do it. If this culture was from an operative specimen, we would combination to treat all these. We could actually choose a medication called tigecycline. It's a tetracycline type product which catches all the 3 organisms. But the principle here is do not swab the skin. pus on the skin probably is full of different bacteria which don't need to be treated. And just as an extreme example, I took this case because all I did was de-roof that dirty looking thing, cleaned it up with saline, and this is what we actually had. There was no infection. This is a squamous cell cancer, which was a change from that overlying seborrheic keratosis. It started off as a seborrheic keratosis. It converted to a squamous cell cancer. And what we were looking as infection would have been missed if we had to just give him antibiotics. So this patient, I did not give any antibiotics. This whole lesion had to be excised. So again, this is a clinical infectious disease journal article. You could read all these antibiotic choices that we have. Vancomycin is often a so-called a big gun or a very strong antibiotic. And we usually use it a lot for skin infections that are very commonly associated with MRSA infection. So we call it a workhorse. But we have a problem with vancomycin, and hence the pharmaceutical companies come up with alternatives to vancomycin. It's difficult to dose. You go very high dose, you have risk of nephrotoxicity. If you go low dose, you don't get good skin penetration. And in America, we don't usually have too many skinny people. We have usually some little big people. So it's very difficult to attain therapeutic doses. The dose that's recommended is like 20 milligrams per kilo, 2 milligrams per kilogram, 2 milligrams per kilogram Q12 hours. So it's very high doses. And then patients are keeping on, with more exposure to the same drug, you have increased minimum inhibitory concentration. So we need higher and higher doses for this medications. So we call it the MIC creep. We are experiencing patients who keep coming back with infections that they need higher and higher doses of antibiotics to achieve therapeutic levels. And there's some studies that question whether we can use combination antibiotics, vancomycin plus gentamicin, vancomycin plus rifampin. And there are studies depending upon what is the clinical scenario. So this is the creep. Anything that was less than 1, we used to say is vancomycin sensitive. But when you start seeing 1, 1.5, 2, although they still call it susceptible, there's increased risk of failure of treatment. So we have to use alternative antibiotics, which could be something like daptomycin. And these are all pills. So if vancomycin is going to fail, we are going to try to use daptomycin. So failures in patients with higher MICs. So all the articles, why we have to achieve very high therapeutic levels, which reduces the safety of the drug. And hence the studies for other organisms, other antibiotics. So daptomycin is a new antibiotic which is given once a day. It's safer. But again, I showed you a slide where you can have an organism which is resistant to daptomycin. So cultures are very important. This is usually not beneficial. And then the more you use, the more likely the bacteria are going to get smart, and so they might develop resistance. So we have newer antibiotics. One is, it's not so new anymore. It's called linezolid or Zyvox. We have this drug. Big advantage of this is it's available by mouth. So patient can take the pills and go home, and equally good bioavailability as IVs. It's got excellent lung penetration. But the problems with a lot of our folks in America have some anxiety disorder, some depression, and this drug interacts with SSRIs and MAO inhibitors. So that's one of its limitations. It's also extremely expensive. It's twice a day, so a new advancement over the linezolid was once a day, tedizolid. These are some of the other antibiotics that are available in the market. I think teicoplanin is available in Europe. We don't have it in America. And then vaccines. There's a lot of studies that are ongoing in terms of use of. A lot of antibiotics that are studies that are going on in the use of vaccines for MRSA. Topical antibiotics. Short note about duration of therapy. We have been more and more, as we learn treatment of infectious disease, we have seen that previously we would treat for 3 weeks, 4 weeks. We are now seeing that there's no potential benefit for that. We are going with shorter and shorter courses, not to save money, not to save healthcare costs, but because of increased risk of side effects the longer we treat. So study shows that in uncomplicated cases, we can actually treat for a very short period of time. And that comes to also the duration of therapy depends upon the depth of the infection. If you have a superficial infection, 5 days, 7 days. But if you have deeper infections, osteomyelitis, that goes down to like 4 weeks, 6 weeks. These are the things that we have to look into when we are taking care of patients with skin infections. Patients with neutropenia, asplenia, HIV, they have very unusual organisms, while the rest of us, if we have cellulitis or abscess, we'll probably be infected with staph and strep. A few mimics here, and I would encourage you to put up your hand and scream the diagnosis if you know it. This is something we see in the New England area. I think we may see a little bit of cases in Europe. Anybody wants to, like, borreliosis or Lyme disease. So this is not the typical staph and strep. This is caused by a tick bone. This is a tick that's sitting there, and you have to just hold it with a tweezer and gently pluck it out. And then the treatment is with doxycycline or ceftriaxone. So I've had consults where the patient has been given, like, Bactrim. Oh, he's not getting better. In fact, he's spreading, correct? The ring is becoming bigger. So I say, please give him IV antibiotics. But actually the diagnosis is not skin infection, it is Lyme disease. This is something that we see in clinics with the vascular stasis. And this is like what they used to call eczema craquale. Stasis dermatitis with cracking skin. This is not cellulitis, and the treatment for this is like treatment of the venous stasis and topical steroids probably. You know this? Anybody wants to tell us? Sorry, my co-chair cannot answer all the questions. Anybody wants to tell us what this is? Yeah, acne conglobata, and when you put this in the groin area, you would call it hidradenitis suppurativa. And so we send these patients again and again, oh, this is infection, this is infection. Actually, it is infection, but it's superadded over an apocrine gland abnormality. So unless the dermatologist or somebody takes care with this isotretinoin or retinoids for this poor patient is going to keep coming back for antibiotics. So this is hidradenitis suppurativa. I'll show you a couple of slides, and then you can tell me what this diagnosis is. Anyone? So these are mimics of infection. They're sent to us not by dermatologists. They're sent to us by general practitioners. They give them some antibiotics and they're not getting better. They say, oh, send it for the big guns. This is bullous pemphigoid. So the treatment of this is actually contrary to what the infectious disease doctor likes. He hates steroids, correct? The infectious disease doctor hates steroids because they make infection bad. But then this is well-defined diagnosis. So this is bullous pemphigoid. Now as a teaser, I have this patient. This patient is a 75-year-old retired lady, goes down to Florida, spends time at the beach, and then comes back with this. So this was her bullous lesion. I just aspirated it. The choice was, please, what antibiotic should we use? Yeah, this is phototoxic dermatitis. She developed a bullous lesion because she put her foot in the sand and got burned. So, photo or heat burns or whatever. And she got better without antibiotics, topical care. Another teaser for you, this could be anything, correct? Dr. Martin is here. And Dr. I mean, when you biopsy, I don't know, clinically, can any dermatologist tell me what this is? Oh, no, it's not Leishmania in America. We do get in travelers, and I think we do see Leishmania in some parts of the US. This is New England, and no history of travel. I think it could be anything. You need to excise this. Anybody wants dermatofibromyosarcoma, whatever you want. Yeah. So it just turned out to be a melanoma, actually, a deep-seated melanoma. So it could be anything. So this needs to be excised. This is not an abscess. The people were sent to us for IV antibiotics. Quick teaser here. A patient was sent to me because he had just returned from another state, taken his children out for dinner to a Chinese restaurant, enjoyed himself, came back with this red rash. His primary care physician put him on cefazolin. The rash went away. Then he went with his kids again to have another lunch, went to the same restaurant, got the rash again. So he was sent to me for IV antibiotics. The diagnosis is just by history taking. He was allergic to the food that he was eating. So spongiotic dermatosis was seen on the biopsy. And then, I have patients who are sent to me like this, and they say, give antibiotics, and I say no. Give antibiotics, and I say no. So what's the diagnosis? No? This is a good differential. But if this is on the hands, this is on the legs. This is pustular psoriasis. Again, you want to treat, no use of antibiotics. So pustular psoriasis, or von Chambusch, they call it. This is a patient who was sent to me for severe cellulitis, and I said, why is this cellulitis so located here? She had radiation too in this area. It turned out to be mycosis fungoides, cutaneous T-cell lymphoma. And this was pityriasis rosea, another consult to me that comes for antibiotics, but this is is it a viral infection? PR, pityriasis rosea. Have you all decided whether it is a viral infection?
It can be associated.
Can be associated. And this is my last slide. It's very nice. You don't get infection in the form of petals, rose petals. This is vasculitis. This is probably a vasculitic reaction to a virus. We never found out why it was. So this is my team in the infectious disease group. We are here in New Orleans, but we are Patriot fans down there in New England. So don't throw stones at me. And any questions?